Welcome, everyone, to vpod.ai. This deep dive is proudly sponsored by Stonefly, your trusted partner in advanced technology solutions. You can learn more over at stonefly.com. Okay, let's unpack this. Today, we're taking a deep dive into something incredibly common, yet maybe often misunderstood. Basal Cell Carcinoma, or BCC. You might think you know about skin cancer, but honestly, this deep dive is going to reveal some truly surprising facts and crucial insights that could, well, literally change how you view your own skin health.
Indeed. Our mission today really is to equip you with a comprehensive understanding of BCC, everything from its fundamental nature and how it impacts the body, right through to the latest advancements in detection and, frankly, some groundbreaking treatments. We'll explore why it's so common, what it actually looks like, because it can look like different things, and most importantly, what vital steps you need to take if you suspect you or someone you care about might have it.
Right. So what does this all mean for you, the listener, tuning in? It means getting a kind of shortcut to being exceptionally well-informed about a health topic that, well, it touches millions of lives globally. We're going to break down complex medical information into hopefully easy-to-understand nuggets, empowering you to recognize those crucial risk factors, identify the often subtle warning signs, and navigate the diverse and evolving landscape of treatment options with more confidence.
Understanding basal cell carcinoma, the most common cancer you might not know enough about.
Okay, so maybe one of the most surprising facts we found about BCC is just how prevalent it really is. I mean,
Yeah.
basal cell carcinoma isn't just the most common form of skin cancer. It's the most frequently occurring form of all cancers. Just let that sink in for a moment.
It's staggering, isn't it?
Yeah. To put that number in perspective, BCC cases annually outnumber lung, breast, prostate, and colon cancers combined. Yet, for something so common, it kind of flies under the radar compared to its more aggressive cousins. Why is that, do you think?
That's a crucial distinction. And what's fundamentally fascinating here is its cellular origin. Where does it start? Well, BCCs arise from the uncontrolled abnormal growth of basal cells. These are cells nestled deep within the epidermis. That's the outermost layer of your skin.
Okay.
Now, these are normally essential cells. They're constantly dividing, sort of like a cellular conveyor belt. They form new cells that then push upwards, replacing the squamous cells on the skin's surface as they naturally shed. So in their healthy state, basal cells are literally the engine of your skin's constant renewal and repair process.
And thankfully, despite this incredible prevalence, there's a very positive aspect to BCC, right? They're typically slow growing.
That's generally true, yes,
Yeah.
still growing.
Which means the vast majority are curable, and they usually cause minimal damage when, and this is the key part, caught and treated early.
Exactly.
That early detection piece, as we'll probably keep saying throughout this deep dive, is absolutely critical. This isn't usually a fast-moving, aggressively spreading cancer, which, well, it provides a significant window for intervention.
To truly grasp why BCCs form and how they behave, we need to take a quick but insightful look at the organ where they start. Your skin. It's your body's largest organ. Stretches to about 20 square feet in an average adult, acting as this extraordinary barrier. It's your primary shield.
Right. Protecting us from everything outside.
Exactly. Protecting you from external threats like bacteria, viruses, environmental toxins, and it plays a vital role in regulating your body temperature too.
And this amazing organ is structured in three main layers, each with its own job. Let's quickly walk through them. First, the epidermis. That's the top, outermost layer. Think of it as your body's waterproof protective shield. It's also where your skin color, melanin, is produced. And within the epidermis, there are three main cell types we really need to know about for this discussion. Squamous cells. These are flat, scale-like cells in the upper part. They're constantly being shed and replaced. Basal cells. These are the deeper ones, right at the very base of the epidermis, just above the next layer down. They're the powerhouse, constantly dividing, forming new cells that migrate up.
Right, the cell factory.
Exactly. And then melanocytes. Also in that lower part of the epidermis, these specialized cells produce melanin.
Ah, the pigment producer.
Yeah, the pigment that gives us our hair, skin, and eye color. And crucially, melanin acts like a natural internal sunscreen, offering protection against those harmful UV rays. Then below that is the dermis, the thick middle layer. It provides structure and nourishment. It's packed with connective tissue, blood vessels, glands, nerves, hair follicles, all the infrastructure.
The support layer.
And finally, the hypodermis, the deepest layer, mostly fat and connective tissue, Acts as an insulator, helps regulate temperature, and gives some cushioning.
Got it. So most skin cancers, including BCC, they primarily form in the cells of that top layer, the epidermis, which leads us to a really fundamental question. What causes these basal cells, which are normally so orderly and, essential for skin renewal, to suddenly go rogue? Why do they start growing out of control, kicking off a cancerous process?
Yeah, that's the core question, isn't it?
It really is. It's pivotal for understanding it and developing treatments.
And the numbers really do underscore just how widespread BCC is. It's a serious public health concern. In the U.S. alone, an estimated 3.6 million BCC cases are diagnosed each year.
This is a huge number.
A staggering figure, really reinforcing its position as the most common cancer. Full stop.
And if we broaden our view, connect this to the bigger picture. Well, more than 1 out of every 3 new cancer diagnoses are skin cancers.
Wow. 1 in 3.
Yeah. And of these, the vast majority, especially in Caucasian populations, are BCCs. We're talking roughly 80–90% of non-melanoma skin cancers. And we've actually seen a significant surge in recent decades. The diagnosis and treatment of non-melanoma skin cancers, that includes both BCC and squamous cell carcinoma, SCC, it rose by a dramatic 77% between 1994 and 2014.
77%, that's alarming.
It is. And this trend really underscores the critical importance of not just understanding this disease, but also embracing proactive prevention.
The roots of the problem, causes, and risk factors.
Okay, so what's the primary culprit then? The main trigger for this uncontrolled growth in basal cells?
Well, the main cause is crystal clear. It's extensive exposure to ultraviolet, or UV, radiation.
From the sun, obviously.
Predominantly from the sun, yes. But it's absolutely crucial to remember it's also, and just as damagingly, emitted by indoor tanning beds.
Right. Those tanning beds are a major issue.
They really are. It's a direct assault on the fundamental building blocks of your cells.
So how does UV actually do the damage?
That's the key. UV radiation directly damages the very genetic blueprint within the basal cells, their DNA. Think of your DNA as the cell's master operating manual, right? It has all the instructions for how a cell should grow, divide, function.
Okay.
When that manual gets corrupted by UV damage, these basal cells can mutate. They become abnormal, and then they can start to grow out of control. That's the very definition of cancer.
It's like typos in the instruction manual leading to chaos.
Exactly. It's a cascade effect, starting with molecular damage that leads to uncontrolled cell growth.
Now, while UV exposure is clearly the primary cause, it's also true that certain factors can significantly increase your individual likelihood of developing BCC, right? It's not just about sun exposure alone.
That's right. It's often a complex interplay between that environmental exposure and your unique genetic makeup or specific health circumstances.
Okay.
So let's break down these key risk factors. Understanding them can really empower you to take more protective action. First, UV light exposure. This is unequivocally number 1. And it's not just about getting, few intense sunburns.
Right, it's the long game.
It's the cumulative exposure over time that really builds up. It causes incremental DNA damage day after day, year after year, even seemingly harmless everyday exposure, walking to your car, sitting near a window. It all adds up over your lifetime.
Makes sense. What else?
Skin, hair, and eye color. Individuals with lighter skin tones, maybe red or blonde hair or light-colored eyes, are at a significantly higher risk.
Why is that?
It's due to melanin, your skin's natural pigment. Melanin acts like a filter, absorbing and scattering harmful UV rays. People with less melanin simply have less natural protection. Their basal cells are more vulnerable to that UV-induced DNA damage.
Okay, so less natural defense.
Precisely. Then there's age. The risk generally increases with age. This is largely because sun exposure accumulates over decades. Older individuals have simply had more time for that UV damage to build up in their cells.
But it's not just an older person's disease anymore, is it?
That's a critical point. Skin cancer, including BCC, is becoming alarmingly more common in younger people.
Really?
Yes. And this trend is likely linked to changing recreational sun exposure habits and the prevalent use of those indoor tanning beds we mentioned, which expose users to really concentrated UV radiation.
Right. Okay, what else increases risk?
A history of skin cancer. If you personally or a close blood relative has had any type of skin cancer, BCC, SCC, or melanoma, your risk goes up substantially.
So if you've had one, you're more likely to get another.
Definitely. Having a previous BCC indicates a predisposition. New BCCs often form within 5 years of the first one, and a family history suggests either a shared genetic susceptibility or maybe similar patterns of sun exposure within the family.
Got it. What about other medical factors?
Radiation therapy. Prior radiation treatment for other medical conditions, especially if it was done at a young age, can significantly increase the risk of developing skin cancer, including BCC, in the specific area that was irradiated, sometimes years or even decades later.
So the treatment itself can cause a later risk.
Unfortunately, yes. The radiation used to treat one condition can cause the DNA damage that leads to a new cancer later on.
Anything else?
And finally, immune suppression. People with weakened immune systems are at higher risk. This could be due to organ transplants requiring immunosuppressive drugs or conditions like autoimmune diseases or HIV.
How does that increase risk?
Their body's natural ability to detect and destroy abnormal cells, including those early cancer cells, is compromised. It allows potentially cancerous cells to grow unchecked.
Okay, that covers a lot of ground. So UV is key, but genetics, age, medical history all play a role.
Exactly. Which brings us to genetics more directly. Are there specific genes involved beyond just, skin type?
Yeah, are there specific genetic conditions?
The answer is a definitive yes. While maybe not as common as the environmental factors, some direct genetic predispositions can significantly ramp up BCC risk.
And one really striking example here is a condition called Gorlin syndrome, right? Also known as nevoid basal cell carcinoma syndrome, or NBCCS.
That's right.
Imagine being a child or teenager and already facing multiple cancer diagnoses. That's the tough reality for people with Gorlin syndrome. It's a rare genetic condition that basically rewires how their basal cells behave.
It makes them highly susceptible.
Highly susceptible to developing multiple BCCs at a very early age, sometimes even in childhood or adolescence, which is quite different from the usual sporadic BCCs we see in older adults.
And molecular analysis has definitively linked Gorlin syndrome to inherited mutations in a specific gene.
Or
The PASH1 gene, or PTCH1.
PTCH1.
Yeah. This gene plays a crucial role. It acts like a natural brake within something called the hedgehog pathway.
The hedgehog pathway. Sounds interesting.
It is. It's a fundamental cellular signaling pathway. It's vital for embryonic development, but also really critical for regulating cell growth and differentiation in adults. When this pathway gets dysregulated, like if the brakes are lost due to a PTCH1 mutation, it leads to uncontrolled cell proliferation.
Like a car with no brakes.
Exactly. And this dysregulation of the hedgehog pathway is now known to be a key mechanism, not just in hereditary cases like Gorlin, but also in the vast majority of sporadic, non-hereditary BCCs.
Wow, so that pathway is central.
Absolutely central. And that understanding has made it a key target for some of the modern therapies we'll discuss later.
Okay. And beyond Gorlin syndrome, are there other, maybe more common genetic factors?
Yes, even more subtle ones influence risk. For instance, mutations in the melanocortin-1 receptor, or MC1R gene.
MC1R, what's that linked to?
MC1R is deeply associated with the red hair phenotype. Red hair, fair skin, freckling, and that tendency to burn rather than tan.
Ah, okay. The classic signs of high sun sensitivity.
Right. People with these genetic variants naturally have less of the protective dark pigment, eumelanin, and more of the photosensitive red-yellow pigment, pheomelanin. But here's the crucial part. Studies strongly indicate that MC1R mutations significantly increase the risk of BCC, even if someone doesn't have visibly red hair or obviously fair skin.
Really? So you could have brown hair and still have this risk factor?
Yes, you might tan a bit, but your underlying risk from these variants is still elevated. Individuals with 2 or more MC1R variants have a heightened risk, and it's partly because their melanocytes, the pigment cells, with these faulty MC1R mutations, have an impaired ability to repair UV-induced DNA damage.
So it's a double whammy, less natural protection and poorer repair mechanisms.
Exactly, which is why these genetic links are so important in fully understanding individual susceptibility to BCC. It's not just about how much sun you get, but also how your body handles it at a genetic level.
Spotting the signs' appearance and early detection.
Okay, so let's talk about what to look for. What does a basal cell carcinoma actually look like? Because as you said, it doesn't always look the same, does it?
No, it definitely doesn't. And this diversity in appearance is precisely why it's so crucial for you, the listener, to be vigilant. You need to be aware of the various ways it can show up. It's often not a textbook mole or an obvious lump.
Right, so what are some of the common presentations?
Well, BCCs can manifest in a surprisingly wide range of ways. They usually appear in sun-exposed areas: face, scalp, neck, ears, arms, legs, trunk. Here are some things to watch out for. One classic sign, though often overlooked, is open sores that just don't heal.
Like a cut that stays open for weeks.
Exactly. It might persist for weeks, even months. Sometimes it oozes, crusts over, it might itch or bleed really easily with just minor trauma. And it just doesn't respond to typical wound care like a normal scrape would.
Okay, persistence is key there.
Right.
What else?
You might see red patches or irritated areas. These can sometimes be itchy or tender, maybe look a bit scaly. They could be mistaken for benign things like eczema or psoriasis.
So how do you tell the difference?
Again, persistence. A normal rash or irritation usually resolves. These BCC patches just stick around. They don't go away.
Got it. Persistent red patches.
Then there are the small pink or red shiny bumps. This is often what people picture.
The pearly bump?
Yes, they often have a translucent, pearly appearance, almost like a waxy pearl, giving them a subtle shimmer. A very characteristic feature you might see are distinct, fine blood vessels on the surface. Those are called telangiectasias. Tiny, dilated blood vessels, almost like little red threads.
Okay, pearly bump with little blood vessels.
You're right. And these bumps can sometimes have areas of blue, brown, or even black pigmentation within them, especially in people with darker skin tones.
Ah, so they aren't always pink or pearly.
No. Another presentation can be scar-like areas. These can be flat, maybe white, yellow, or waxy in color. They might feel firm to the touch.
Like an old scar that just appeared.
Kind of. It might resemble an old scar where you don't remember an injury, or just a slightly depressed area in the skin. This subtype can be particularly deceptive because it doesn't look like a typical growth.
Tricky. Any other common looks?
Yes, sometimes you see growths with slightly elevated rolled edges and maybe a central indentation.
Rolled edges.
Yeah, imagine a small raised border surrounding a depressed center, which might even be ulcerated or crusted over, sometimes called a rodent ulcer appearance. That rolled border often has that translucent, pearly quality we mentioned.
Okay, that's quite a range of appearances.
It really is.
And you mentioned pigmentation, especially in darker skin. That seems really important.
Absolutely critical. About half of BCCs in patients with darker skin tones are pigmented, meaning they can be tan, black, or brown.
So they could easily be mistaken for just a normal mole or freckle.
Exactly. Or even a bruise or some other benign spot. This potential for misdiagnosis is a serious issue because it can unfortunately delay crucial treatment, which can lead to more disfigurement if the BCC grows.
That really highlights the need for awareness across all skin types.
It absolutely does. So while BCCs can look quite different from person to person and from subtype to subtype, the overarching message is crystal clear. If you notice something new on your skin, or an existing spot that is changing in color, size, shape, or texture, or any lesion that seems unusual, persists, bleeds easily, or simply doesn't heal, you need to schedule an appointment with your healthcare provider, ideally a dermatologist, as soon as possible.
Don't wait and see.
Definitely don't wait and see. Proactive evaluation is absolutely key.
And this really hammers home the power of early detection.
It's the most powerful tool we have, truly. When caught early, BCC is significantly easier to treat and cure. Often requires much less invasive procedures.
And that applies to all skin cancers, right?
Universally. The sooner you find and treat them, the better your outcome, the less complex the treatment usually needs to be. It can literally be the difference between a simple office procedure and more complex surgery with greater cosmetic impact.
So how do we maximize that early detection?
It's a two-pronged approach. First, regular self-exams. Really get to know your own skin. Check yourself meticulously, head to toe. Use mirrors or get a partner to help check hard-to-see areas like your back and scalp.
Make it routine.
Exactly. And second, annual professional skin exams by a healthcare provider, ideally a board-certified dermatologist. They have the expertise and tools, like the dermatoscope we mentioned earlier, that special magnifying lens with a light. It lets them see subtle patterns and characteristics invisible to the naked eye that can strongly suggest malignancy.
So both self-checks and professional checks are vital.
Absolutely. And remember, you know your skin best. So communicating any changes you've noticed in color, texture, growth is vital to guide their examination and ensure nothing gets missed.
BCC's many forms and their implications.
We've talked about the general appearances, but you mentioned subtypes. BCCs actually come in different clinical subtypes, each with its own characteristics.
That's right. Based on how they look clinically and, importantly, how they look under the microscope, their histology, we classify them further. This is crucial because different subtypes can behave differently and might require different treatment approaches.
Okay, so it's not just one type of BCC.
Not at all. Let's break down the main clinical subtypes identified in the source material. We can group them into maybe the classic look, some trickier ones that tend to be more aggressive, and that pigmented variant we touched on.
All right, let's start with the classic.
The most frequent is nodular BCC. This accounts for over half of all cases. It's that classic, well-defined, pearly, shining, translucent bump or nodule we described.
The pearly bump again?
Yes, often with those distinct dilated blood vessels, the telangiectasias, on the surface. As it grows, it might get that central depression or ulceration, crust over, bleed easily, that rodent ulcer look. Its boundaries are usually pretty clear.
Okay, nodular. What's next most common?
That would be superficial BCC. This makes up maybe up to 15% of cases. It typically looks different, more like an annular or ring-shaped, well-defined, thin plaque or patch.
So flatter like a patch.
Exactly. And unlike nodular BCCs, which love the head and neck, superficial BCCs often pop up on the trunk and extremities, so they can sometimes be mistaken for eczema, psoriasis, or just a persistent rash. They often have fine, slightly raised borders.
Okay, so nodular and superficial are the most common. Now for the trickier ones.
Yes, these tend to be more aggressive in their growth patterns and sometimes harder to spot. One is morphic, or sclerosing BCC. This accounts for maybe 5–10% of BCCs.
Morphic. What does that look like?
These are challenging because they show poorly defined scar-like features, or maybe shining plaques that are flat, or even atrophic, meaning thin and depressed. Their boundaries can be really inconspicuous, blending into the surrounding skin. And they tend to infiltrate, spreading subtly beneath the surface like the roots of a plant.
Wow, that sounds hard to diagnose and treat.
It absolutely is. It makes judging the true extent difficult clinically, leading to a higher risk of incomplete removal if you don't use specialized techniques.
Okay. Any other aggressive subtypes?
Yes. Micronodular BCC. Under the microscope, this is composed of dispersed micronodules of tumor cells that extend more deeply into the skin, sometimes even into the fat layer. These small, irregular nests of cells are separated by normal tissue, making their deeper reach less obvious from the surface.
So they're tunneling down.
In a way, yes. And then there's infiltrating BCC. This one is characterized by irregular strands or cords of tumor cells that deeply infiltrate the surrounding tissue, often with jagged, spiky edges microscopically. This type often overlaps with the morphic sclerosing type because of its aggressive spreading growth pattern.
So morphic, micronodular, infiltrating these are the more aggressive ones to watch out for.
Correct. They require very careful assessment and management.
And then the pigmented variant.
Right, pigmented BCC. As we said, these are black or dark brown nodules or papules, sometimes with ulceration. Clinically, they can really mimic melanoma because of that dark color, especially in fairer-skinned patients where they might be less common but cause more alarm.
But they're more common in darker skin types.
Exactly. In fact, in people of Asian origin, pigmented BCC is the most frequent type, accounting for over 88% of cases in some studies, like those in Japanese patients.
That's a huge difference.
It is. And it emphasizes why looking at the cells under a microscope, the histopathology, is absolutely essential for definitive diagnosis and to reliably tell it apart from melanoma. You can't always judge by appearance alone.
Okay, so understanding these subtypes is important, and you mentioned this ties into risk.
Absolutely. Beyond just appearance and histology, BCCs are meticulously classified based on their risk of recurrence after treatment. This risk stratification is profoundly crucial for guiding management. Higher-risk lesions simply require more aggressive and precise treatment to ensure complete removal and minimize the chance of them coming back.
Right. So how is risk categorized?
It leads to three key categories that really dictate the treatment approach and follow-up. First, low-risk BCC. These are cancers with, well, a low chance of recurring after appropriate treatment. They're typically found on less problematic areas, think trunk, arms, legs. They're usually small, less than 2 centimeters across, often superficial, and have clear, well-defined edges. And importantly, they haven't been treated before or recurred. These often respond well to simpler treatments.
Okay, low risk sounds manageable. What about high risk?
High-risk BCC. These have a significantly higher chance of coming back and demand more aggressive intervention. This category automatically includes any BCC on the face, especially those sensitive mask areas, eyelids, nose, lips, chin, ears, plus the scalp, neck, hands, feet, or shins, regardless of their size.
Location matters a lot then.
Hugely. Also, any BCC on the trunk or limbs that's larger than 2 centimeters is high risk. And critically, any BCC with poorly defined edges, or one that shows those aggressive growth patterns under the microscope, like the morphic, micronodular, or infiltrating subtypes we just discussed, or any BCC that has already recurred after previous treatment, is classified as high risk. These demand more thorough, often specialized techniques.
Okay, high risk needs serious attention. And the third category.
That's advanced disease. This is the most serious, though thankfully extremely rare category. It means the BCC has spread significantly.
Spread where?
Either locally, growing very deep into surrounding tissues, maybe bone or cartilage, making it unresectable by standard surgery, or regionally spreading to nearby lymph nodes, or even metastasized, spreading to distant parts of the body like the lungs or bones.
How rare is that?
Very rare. Occurs in maybe 0.00028 to 0.55% of cases. But when it happens, it carries a very serious prognosis and completely shifts the treatment approach from local removal to systemic therapy.
Got it. And you mentioned the aggressive subtypes under the microscope link directly to this risk.
Yes, that classification directly correlates. The microscopic architecture of morphic sclerosing, micronodular, and infiltrating BCCs inherently places them in the aggressive subtype category. Their infiltrative nature is precisely what makes them difficult to treat sometimes, often necessitating highly specialized surgical techniques like Mohs surgery to ensure clear margins.
Okay. Now, we often hear skin cancer as this broad term. It's vital to understand the differences between the main types, right? What really sets BCC apart from squamous cell carcinoma, SCC, and melanoma?
Great question. Yes, they're all skin cancers, but they behave quite differently. BCC and SCC are both non-melanoma skin cancers. They start in different epidermal cells, basal cells for BCC, squamous cells for SCC. SCC is generally considered more aggressive than BCC.
More aggressive how?
SCC is more likely to grow deeper into the skin layers and has a higher tendency to spread or metastasize to other parts of the body, like lymph nodes or distant organs. This can significantly impact the outlook. BCC, in contrast, is often called the most harmless type in terms of its metastatic potential because it very rarely spreads beyond the original tumor site.
But that doesn't mean it's harmless if ignored.
Absolutely not.
Yeah.
If left untreated, BCCs can still grow wide and deep, causing significant local tissue destruction, disfigurement, and damaging adjacent skin, tissue, even underlying bone. So while less likely to be life-threatening by spreading, it can still cause serious local problems if neglected.
Okay. And then there's melanoma, often called the most serious one. Why is that?
Melanoma is indeed more likely to spread aggressively to other organs, and tragically accounts for the majority of skin cancer-related deaths. It starts in the melanocytes, the pigment cells.
Right.
However, and this is often overlooked, but really reassuring, even melanoma has an exceptionally high 99% 5-year relative survival rate if caught and treated early.
Wow, 99% if caught early. That's incredible.
It powerfully highlights the universal importance of early detection across all skin cancer types.
So looking at the numbers again, BCC and SCC make up the vast majority.
Yes. Combined, they're about 95% of all non-melanoma skin cancers. And BCC outnumbers SCC by roughly 3-to-1 in diagnoses.
Which naturally leads us to think about diagnosis. How are these different types actually diagnosed?
The diagnostic journey from suspicion to confirmation.
Okay, so the diagnostic journey often starts, maybe surprisingly, with you noticing something, right? A scaly patch, a little bump, a sore that won't heal.
Absolutely. Your vigilance, your awareness of your own skin is truly the critical first step in this whole process. You're often the first line of defense.
So if you notice something concerning, you see your doctor.
Yes. If you bring these concerns to a primary care physician, they'll almost certainly refer you to a dermatologist, a specialist in skin conditions. The diagnostic process proper begins with taking a thorough medical and family history. This is vital.
Why is history so important?
It helps build the picture. Listing past health issues, current medications, any family history of skin cancer or other cancers, all this detailed information can significantly influence the diagnostic approach and, later, treatment decisions. It helps the clinician understand your overall risk profile.
Makes sense. What happens next?
Following the history, your doctor will perform a complete physical exam. This includes checking eyes, ears, nose, throat, feeling for any large lymph nodes, neck, underarms, groin. But the most crucial part, obviously, for suspected skin cancer is the full head-to-toe skin exam. And this is far more comprehensive than just looking at the one spot you pointed out.
Head to toe, really?
Yes, it's a meticulous, systematic review of your entire body surface. Scalp, face, inside your mouth, eyelids, ears, neck, trunk, arms, hands, fingers, under the nails, feet, toes, toenails, everywhere.
Wow, thorough.
Very. And as we mentioned, dermatologists frequently use that dermatoscope, the special magnifying lens with a light, to inspect suspicious lesions more closely.
To see things the naked eye misses.
Exactly. It reveals subtle patterns and characteristics that can strongly indicate malignancy. And again, communication is key. You telling the doctor about any changes you've noticed is vital.
Okay, so after the exam, if a spot looks suspicious, what's the definitive step?
The definitive step is a biopsy. It's really important for you to understand this isn't the same as surgery to remove the whole thing. Its primary purpose is diagnosis.
To find out for sure what it is.
Precisely. To get a definite answer about whether cancer cells are present, and if so, exactly what type of cancer it is, like which subtype of BCC, its characteristics.
How is a biopsy done? Is it painful?
Well, first your provider will numb the area with a local anesthetic, usually a small injection. You might feel a quick pinch, but it effectively prevents pain during the procedure itself. Then they carefully remove part or all of the suspicious lesion and send it off to a specialized lab. There, a pathologist examines it meticulously under a microscope.
And the pathologist provides the diagnosis.
Yes, they identify the specific type of cancer cells, if any, noting their size, shape, overall appearance. This provides critical information for planning your treatment.
Are there different kinds of biopsies for BCC?
Yes, there are 3 common types, and the choice depends on the lesion size, location, and characteristics. One is an excisional biopsy. Here, the entire lesion, plus a small margin of surrounding healthy-looking tissue, is removed. If the lesion is small and shallow, this might actually serve as both the diagnosis and the initial complete treatment. Stitches are often needed.
Okay, remove the whole thing. What else?
A skin punch biopsy. For this, a small circular punch tool, kind of like a tiny cookie cutter, is used to remove a cylindrical piece of skin and underlying tissue. This gives a full thickness sample and usually requires a stitch or 2 to close the small hole.
A punch biopsy, got it. And the third?
A shave biopsy. This is typically used for lesions that are raised or seem very superficial. A thin layer of skin, including all or part of the lesion, is carefully shaved off with a sharp blade or scalpel. Stitches usually aren't needed, and they'll apply medicine or use cautery to stop any bleeding.
Okay, 3 main types. Do biopsies leave scars?
That's an important point. Scarring is a likely outcome of any biopsy, since it involves cutting the skin. It's definitely something to discuss with your provider, especially if the lesion is in a cosmetically sensitive area. They might have techniques to minimize the visible scar.
Good to know. Now, what about imaging tests like CT scans or MRIs? Are they used for BCC?
Not typically for most BCCs, primarily because, as we said, they rarely spread beyond the original site.
But sometimes they are needed.
Yes, they become absolutely critical in certain specific situations. If the cancer is very large and seems deep, or if there's a serious concern it might have spread locally into deeper tissues like muscle or bone, or in those extremely rare cases where metastasis to distant organs is suspected, then imaging is indispensable.
What do those scans show?
They provide invaluable internal views. CT scans use computerized X-rays for detailed 3D images. MRI scans use strong magnets and radio waves for highly detailed pictures, especially of soft tissues. These images allow doctors to precisely assess the extent of local invasion, or to see if the cancer has traveled further, maybe to lymph nodes or other organs. This detailed info is essential for accurately staging advanced cases and planning the most appropriate treatment strategy.
The path to treatment options and approaches.
Okay, so once basal cell carcinoma is diagnosed, what's the game plan? What's the goal of treatment?
The overarching goal is always crystal clear. Completely remove the BCC, eradicate every single cancer cell. That's priority number 1.
Complete removal.
Yes, and crucially to do so with the least possible cosmetic and functional impact. This is especially vital since BCCs often occur on highly visible areas like the face. Now, in those exceedingly rare cases of metastatic BCC where it's spread, the goal shifts. It becomes about attaining remission, controlling the disease, and prolonging survival, which requires different systemic approaches.
Makes sense. So the plan depends on the specific case.
Absolutely. Your treatment plan will be meticulously individualized. It's based on the BCC's specific characteristics, its size, location, appearance, the exact histological subtype, and of course your personal health factors, your preferences, your lifestyle.
And even with all the modern advancements, surgery is still the main treatment for most people.
Yes. For the vast majority of patients, surgery remains the keystone, the primary and most effective treatment for basal cell carcinoma. It's the definitive first line of defense in most cases.
All right, let's talk about the main surgical techniques.
Okay, let's look at the primary options, each suited for different types and locations of BCC. First, there's standard excision. This is widely used. It involves carefully cutting out the skin cancer along with a surrounding margin of clinically normal-looking tissue.
A safety margin.
Exactly. Typically a 4 millimeter margin for low-risk primary BCCs. The purpose is to ensure all cancer cells are removed, reducing the risk of it coming back. This is the usual approach for low-risk BCCs and can also be used for some high-risk ones, maybe with wider margins needed. It offers low recurrence rates and often good cosmetic results, especially if the wound can be closed directly.
Okay, standard excision. Then there's Mohs surgery, which sounds quite specialized.
Mohs micrographic surgery, MMS. Yes, this is widely considered the gold standard, the best option for aggressive or difficult-to-treat BCCs, particularly those in cosmetically or functionally important areas: eyes, lips, ears, nose, hands, genitals. It's also strongly preferred for large tumors, those with poorly defined edges, or those that have already recurred after previous treatments.
What makes Mohs so special? You mentioned its precision earlier.
It's the real-time microscopic control. Unlike standard excision, where the tissue goes off to a lab for days, with Mohs, the surgeon removes thin layers of skin one at a time.
Layer by layer.
And immediately evaluates each layer under a microscope right there in an on-site lab while you wait.
Wow.
This technique, sometimes called peripheral and deep end face margin assessment, PDAMA, is revolutionary. It allows for complete tumor removal while minimizing how much healthy skin is taken. The surgeon maps the tumor, removes a thin layer, checks all its edges microscopically. If any cancer cells remain at a specific spot on the margin, they go back and remove only that precise affected area in the next layer.
So it's incredibly precise and tissue-sparing.
Extremely. This layer-by-layer process continues until no cancer cells remain at any margin. It boasts exceptionally high cure rates. One study showed a 93.5% cure rate for primary BCC and 90% for recurrent BCC at 5 years. It's incredibly effective while preserving as much healthy tissue as possible.
Amazing. What other surgical options are there?
Another common procedure is curettage and electrodesiccation, C&E.
Curettage and electrodesiccation. What does that involve?
It's a two-step process. First, the lesion is physically scraped off using a special tool called a curette. It has a sharp looped edge, kind of like scooping out the abnormal tissue. Then the area is electrodesiccated, meaning it's cauterized or burned with electrical currents. This stops bleeding and helps destroy any remaining cancer cells near the surface.
When is C&E typically used?
It's usually for shallow superficial BCCs in less cosmetically critical areas, as it often leaves a round, flat scar. The main drawback compared to excision or Mohs is that it produces multiple tissue fragments, so you can't definitively confirm clear margins histologically. The clinician relies heavily on their skill and judgment to ensure complete removal.
Okay, and one more.
Shave removal or shave excision. For raised or very superficial lesions, a small, sharp blade is used to literally shave off the outer layers of skin, including the lesion. Stitches usually aren't needed, and medicine or cautery stops bleeding. While often used for biopsies, it can sometimes serve as the complete treatment for very superficial lesions, leaving a flat scar.
Okay, so several surgical options, depending on the situation. But what if surgery isn't the best choice? Maybe for health reasons, or if the BCC is very superficial. Are there non-surgical treatments?
Yes, absolutely. There are several effective non-surgical therapies. These are often preferred for superficial BCCs or when surgery is contraindicated or maybe the location makes surgery difficult.
Like what?
While there are topical therapies, these are creams applied directly to the skin for localized treatment.
Creams that fight cancer.
Essentially, yes. Two main ones. Imiquimod. This is an immunomodulator cream. It works by triggering your own immune response right there in the skin, rallying your body's defenses to fight the cancer cells. It also messes with that hedgehog signaling pathway involved in BCC growth. It's approved for biopsy-proven primary superficial BCCs, usually applied several times a week for about 6 weeks. 5-fluorouracil, 5-FU. This is an anti-metabolite cream. It works by inhibiting DNA synthesis, specifically in rapidly dividing cancer cells, stopping their growth and causing them to die off. Also approved for superficial BCCs, typically applied once or twice daily for 3 to 6 weeks.
Do these creams have side effects?
Yes, both can cause local skin reactions, redness, blistering, crusting, itching. It can be quite noticeable and sometimes uncomfortable during treatment, but it's actually a sign the medication is working.
Okay, topical creams. What else non-surgical?
Photodynamic therapy, PDT. This is quite an elegant, often non-scarring treatment.
How does PDT work?
It involves 2 steps. First, a light-sensitive drug, A photosensitizer is applied to the lesion and allowed to be absorbed preferentially by the abnormal cells. Then, after an incubation period, the area is exposed to specific wavelengths of light, often red light. This activates the drug, causing it to selectively destroy the tumor cells with minimal damage to surrounding healthy tissue.
When is PDT a good option?
It's particularly effective for superficial and thin nodular BCCs, usually those less than 2 millimeters thick. It's an excellent cosmetic option, especially when surgery is less appropriate due to location or patient preference. It often gives very good aesthetic results.
Sounds interesting. Any other major non-surgical approach?
Yes, radiation therapy, RT. This uses high-energy radiation, like low-energy photons or electron beams, precisely delivered to the affected area to kill cancer cells and shrink tumors.
When is radiation used for BCC?
It's a valuable option when surgery isn't feasible, maybe due to the patient's overall health or if the patient prefers not to have surgery. It can also be used after surgery if there's concern about involved margins, meaning some cancer cells might have been left behind.
Are there downsides to radiation?
Yes. It's generally not recommended for those more aggressive subtypes like morpheoform or infiltrating BCC, as recurrence rates can be higher. It also carries risks of skin irritation, fatigue, and potential long-term effects, like, rarely, a secondary skin malignancy developing in the treated area years later. This makes it contraindicated in conditions like Gorlin syndrome, where patients are already prone to skin cancers.
Tackling advanced cases, modern systemic therapies.
Now, we've established that most BCCs are treated locally and cured, but let's talk about those rare advanced cases. What happens when BCC spreads or becomes unresectable?
Right. While rare, it's important to understand this scenario. Advanced BCC usually means one of two things. It's locally advanced, lay BCC, meaning it's spread deep into the skin or nearby tissues, muscle, cartilage, bone-making standard surgery impossible, or highly disfiguring. Or it's metastatic MBCC, meaning it's spread to distant parts of the body like lymph nodes, lungs, or bones.
And this is where the prognosis gets serious.
Unfortunately, yes. Metastatic BCC, MBCC is infrequent, as we said, maybe 0.000280, 0.55% incidence, but it carries a dismal prognosis. Locally advanced BCC, lay BCC, often results from delayed diagnosis, repeated treatment failures, or very aggressive tumors. While surgery and radiation might still be attempted for lay BCC, they can cause significant long-term problems or morbidity. This is precisely where modern systemic therapies become profoundly crucial. They offer hope where local treatments aren't enough.
Systemic meaning treatments that travel through the whole body.
Exactly. And the big breakthrough here came from understanding that core molecular driver we mentioned earlier, the hedgehog pathway.
Yes, the pathway that goes rogue in most BCCs.
Precisely. The main driver of BCC growth and progression is the constitutive or constantly active dysregulation of this pathway. This deep molecular understanding has directly led to the development of highly effective targeted therapies.
Targeted therapies, so drugs designed specifically for that pathway.
Exactly. They're specifically called SMO inhibitors. They target the smoothened SMO protein, which is a key switch in the hedgehog pathway.
So they block the signal telling the cancer cells to grow?
That's a great way to put it. They put the brakes on that runaway signaling. And 2 FDA-approved SMO inhibitors have truly revolutionized treatment for advanced BCC. First was vismodegib, Aravig, approved in 2012. This was a real game changer. It's used for both locally advanced lay BCC and metastatic MBCC cases when surgery or radiation aren't options or have failed.
How effective is it?
Clinical trials showed impressive objective response rates, meaning the tumors significantly shrunk or disappeared, of about 60.3% for lay BCC and 48.5% for MBCC after about 3 years. Really significant clinical benefit.
Wow, and the second one.
That's subtypes, Odomzo, approved in 2015. It's primarily indicated for locally advanced lay BCC or recurrent BCC. It showed objective response rates of around 56.1% for lay BCC and a bit lower, 7.7% for MBCC at 30 months. It might have a slightly different tolerability profile for some patients.
And these are pills people take?
Yes, they're oral medications, which is a huge advantage for patients. Allows for at-home treatment, improves quality of life compared to infusion sometimes.
But they must have side effects.
They do. Like all powerful medications, they come with a characteristic set of side effects, often shared between the two drugs. Things like muscle spasms, hair loss, alopecia, altered taste sensation, dysgeusia, weight loss, decreased appetite, nausea, diarrhea, and fatigue are quite common.
And can the cancer become resistant to these drugs?
Unfortunately, yes. As with many targeted therapies, drug resistance can develop over time. This often happens due to specific new mutations occurring in the SMO protein itself, which allows the cancer to bypass the drug's blocking action and start growing again.
Okay, so what happens then if the hedgehog inhibitors stop working or aren't tolerated?
This is where another revolutionary approach comes in: immunotherapy. This strategy harnesses your own body's immune system to fight the cancer. It's a completely different mechanism than the targeted SMO inhibitors.
Helping the body fight itself.
Exactly. And in February 2021, a significant milestone, the FDA approved cemiplimab Libtayo as the first immunotherapy specifically for advanced BCC. This provided another powerful, much-needed tool.
How does cemiplimab work?
Cemiplimab is a type of drug called an immune checkpoint inhibitor. It's a fully human monoclonal antibody that specifically targets the PD-1 programmed death-1 receptor on your immune cells, particularly T cells.
PD-1, what does that do?
PD-1 acts like a brake on the immune system. Cancer cells can sometimes exploit this pathway to hide from immune attack. BCCs, often because they have a lot of mutations from UV damage, a high tumor mutational burden, can produce abnormal proteins, neoantigens, that the immune system should recognize.
So cemiplimab takes the brakes off.
Exactly. By blocking PD-1, cemiplimab essentially releases the brakes on the immune system, allowing T cells to recognize and attack the cancer cells more effectively.
And how well does it work for advanced BCC?
Clinical trials showed objective response rates of about 31% for LabBCC and 21.4% for MBCC in patients who had already failed or couldn't tolerate HHI therapy. This highlights its significant value as a second-line option, giving patients another chance.
How is it administered?
Cemiplimab is given as an intravenous infusion, typically every 3 weeks. Side effects can occur, often related to the immune system being activated, things like fatigue, diarrhea, itching, muscle joint pain, and sometimes more serious immune-related adverse events need careful monitoring.
So targeted therapy and immunotherapy have really changed the game for advanced BCC.
Dramatically. And the field continues to evolve rapidly. We're seeing really promising developments in combination therapies.
Combining different approaches.
Yes. Given that HHIs can actually alter the tumor microenvironment, potentially making it more visible or susceptible to the immune system, combining HHIs with immune checkpoint inhibitors is being actively explored for potentially synergistic effects, hitting the cancer from multiple angles.
What kind of combinations are being tested?
There are ongoing trials looking at cemiplimab combined with pulsonidagib, for example. Studies are also investigating bispecific antibodies like one called XmAb20717 that targets both PD-1 and another checkpoint called CTLA-4 simultaneously. Plus, new SMO inhibitors like talidegib are showing promise in overcoming some types of resistance. And fascinatingly, even an existing antifungal drug, itraconazole, is under investigation because it seems to also inhibit the hedgehog pathway through a different mechanism.
Wow, repurposing an antifungal, that's innovative.
It is. The pipeline for advanced BCC treatments is robust. It really highlights the dedication in the medical community and offers significant hope for future patients facing these difficult situations.
Long-term care, follow-up, and prevention.
Okay, so let's say treatment was successful, the cancer is gone. That's great news, but it's not quite the end of the story, is it? What does long-term monitoring and follow-up care look like?
You're absolutely right, it's not the end. Follow-up care is crucial and really represents a lifelong journey for anyone who's had a BCC.
Lifelong. Why is that?
Because even after successful treatment for one BCC, having had it significantly increases your risk for developing other types of skin cancer down the road. Not just another BCC, but also squamous cell carcinoma and even melanoma. Your risk profile has changed.
So vigilance is key, long-term.
Paramount. The recommendation is very clear. You should have a complete skin exam performed by a healthcare provider, ideally a dermatologist, every 6 to 12 months for the first 5 years after your BCC treatment.
Every 6-12 months for 5 years. And after that?
After that initial period, you should continue to have at least one professional skin exam every single year for life.
Okay, annual checks for life.
Yes. But remember, you are truly your own best advocate here. Regular self-examinations are vital. Make it a routine, maybe once a month, to meticulously check your own skin head to toe. Use mirrors. Get a partner to help with your back and scalp.
Know your spots.
Know your spots. And if you notice anything unusual in your skin between those professional visits, any new spot, any existing spot, changing color, size, shape, texture, bleeding, not healing, contact your doctor immediately. Don't wait for your next scheduled appointment. Early detection is always better.
Absolutely.
Yeah.
Now, prevention. While you can't completely prevent skin cancer, you can significantly lower your risk of getting future ones, right?
Yes, you absolutely can. This knowledge empowers you to take proactive, impactful steps every single day to protect your skin.
So let's quickly recap the most important prevention strategies. What's the best advice?
It boils down to minimizing UV damage, first and foremost. Reduce UV light exposure. This is fundamental.
Meaning stay out of the sun.
Minimize direct exposure, especially during peak hours, and completely avoid indoor tanning beds. Just don't use them, period.
Okay, avoid tanning beds, limit peak sun. What else?
Prevent sun damage actively. Limit your time in direct sun, especially between 10:00 p.m. when UV radiation is strongest. Seek shade whenever possible. Trees, umbrellas, awnings, make shade your friend.
Makes sense?
Clothing, absolutely. Wear protective clothing. This acts as a physical barrier. Think wide-brimmed hats that shade your face, neck, ears. Choose clothes made with UV protective fabric. Look for a UPF rating. And don't forget sunglasses that block both UVA and UVB rays to protect your eyes and the delicate skin around them.
Sunscreen is obviously important too.
Hugely important. Use sunscreen consistently and correctly. Choose a broad-spectrum sunscreen, meaning it protects against both UVA, aging, and UVB burning rays with an SPF of at least 30. Higher is often better.
How should you apply it?
Apply it liberally to all exposed skin about 15 minutes before you go outside so it has time to bind to your skin. And, crucially, reapply every 2 hours or more often if you're swimming or sweating heavily. Don't forget spots like ears, back of the neck, tops of feet.
Consistency is key with sunscreen.
Absolutely. And finally, reinforcing what we just said about follow-up. Regular skin exams. That combination of your own monthly self-exams and your annual professional skin checks is your absolute best defense for catching anything suspicious early. Outro.
Wow. This deep dive really highlights how understanding something as common as basal cell carcinoma can be such a powerful tool in your personal health journey. From recognizing those subtle, often tricky warning signs to knowing about the incredible precision of treatments like Mohs and understanding these breakthroughs in targeted therapies and immunotherapies for advanced cases. There's just so much to learn and apply.
Indeed. The rapid advancements, especially in understanding the molecular mechanisms like the hedgehog pathway and the development of personalized treatments, SMO inhibitors, immunotherapies, they are genuinely transforming the outlook for BCC patients, even in those advanced, historically challenging situations. And the ongoing research into new therapies, new combinations, it offers immense hope for even better outcomes in the future. It's a very active area.
So what does this all mean for you, our listener, as we wrap up? It means being informed. It means being proactive about your skin health, taking those simple but crucial preventative steps we talked about, and maybe also knowing that there's a really dedicated medical community continuously working to improve outcomes and expand treatment options.
Absolutely. Which brings us maybe to a final important question for you to consider. How will you integrate this knowledge, this awareness into your daily life? How will you use it to protect your skin and ensure early detection, not just for yourself, but perhaps for those you care about too? Maybe encourage them to be vigilant as well, share this vital information.
That's a great closing thought. Before we go, just a reminder that this deep dive was brought to you by Stonefly, your trusted solution provider and advisor in enterprise storage, backup disaster recovery, hyper-converged VMware, Hyper-V, Proxmox cluster, AI servers, SA365, a turnkey security appliance, public and private cloud. And speaking of cutting-edge solutions, especially for those building robust, secure digital infrastructures, Stonefly offers powerful protection. You can now get a 100 TB immutable and air-gapped SSO NAS for just $8,995. That's a really powerful, secure solution at an incredible value. You can check out stonefly.com for more info on this and their other enterprise solutions. Thank you so much for joining us on this deep dive. We really hope you feel much more informed and empowered about BCC. See you next time.